So, yeah, we're about 25 minutes behind schedule. So I'm going to try to figure out how to cannibalize some of the time for the discussion around the voting, and also probably some of the time even from the policy roundtable. But we'll see how we do. So we're going to have the ICER research team move up there. While we're doing that, just really briefly, as a segue, I know we have to get another voting question tested, don't we? Why don't we do that, and then I'll ask a question of the patients at the front table. Ellie, you want me to lead this? All right. So just to make sure that all of the CEPAC members, 17 of you, are in the voting system, here's the test question. What was the original name of Chicago O'Hare Airport, which gave it its abbreviation, ORD? Orlando Donovan Airport, Orchard Field Airport, Oberlin Douglas Airport, Ontario Development Airport. No, here we'll have probably some variation, but I'm just making sure that, does anybody feel like they're not in the system? Okay, good, we're sorting this out. Okay, well, that's why we're doing it, we'll sort it out.
There must be one extra person logged in.
Maggie, do you have any idea, or does Ellie have to come through? It's all right, no breaks. We were going to take a break soon, but we'll do it. Are we still Tim, are you still locked out?
Yeah, he is too.
Should we try to reboot the system?
Grab them quicker. It's just
Oh, no.
close it and then open it again. It'll kick everyone off.
Okay. Should we just try it again? Sure.
You're all going to be kicked off. We're going to restart it. Apologies.
Have to rename it. Sure. You tell me. So everybody try to log back on. The session ID now is called CTAF. Your kith and kin out in California. AF. Yep. And if they're logged in, should they go ahead and vote again on the question? I can. Should I just close it? Sorry about this. Okay, we're accumulating responses. Is anybody still not in the system? All right, we've got one. Two more. We're almost there. One more. All right. Well done. So let's see. All right. Orchard Field Airport was the odds maker's favorite, and the answer is? That is correct. Orchard Field Airport. Very well done. I always think of orchards when I think of Chicago. All right, well done. Okay, let's move forward. Here's the first voting question. What we're going to do is to vote on the clinical effectiveness of esketamine and several different kind of permutations. And I want to preface this, though, by acknowledging that we've had, our two patient representatives up here. And I want to get their reflection We're going to be now talking about the evidence being adequate to demonstrate whether the health benefit, considering both the risks and benefits of esketamine plus a background antidepressant is superior to that of just the background antidepressant alone. Is there anything about the evidence and your experience thinking about the evidence and how it applies to this kind of question that you'd like to share with the group before we start broader conversation? Phyllis.
Sure. Thank you so much for that opportunity. Something that I would like to share is a survey that the Depression Bipolar Support Alliance did in 2017 with our Scientific Advisory Board, just asking our community their thoughts on medication. And 20% of those who responded said that a health reason was a reason for switching of medication. And 51% said that a health reason was a reason for not taking any medication to treat their depression. So I think that as you're looking at the evidence, one needs to consider, what is the unmet need? Are there enough options out there that don't have the detrimental effect to someone's overall net health?
Thank you. Pam, anything?
One of the things that has been most important for me has been, and I know that this has been measured to some extent in the program that I've been in at Mass General, is the increase in cognitive functioning that you can experience when your depression is lifted. I work full-time in healthcare informatics. At the time I got to the ketamine clinic, I had to reduce my hours to part-time because I was not able to function effectively due to depression-induced cognitive functioning disorders. And I know that I had baseline scores taken, and I know that after the treatment was started, I was able to return back to work. I could tell I was functioning better, but I also could tell when I took a second round of cognitive functioning testing that not only were my scores improved, but the way I was approaching my thoughts about the test had improved. So there are things that can be measured and modeled about this that can show effectiveness that I think maybe haven't been addressed in some of these studies. But it did, in my case, allow me to return to work full time, and I feel like it's greatly improved my ability to concentrate and function, as well as improving my mood.
Thank you. That gives even more kind of flavor to some of the comments that Mr. Sperling was making earlier, too. That's very helpful. Clinical experts, don't worry, your time is coming, too. So the question is about, and maybe I'll get your quick input on this first. And I know some of you had questions that we couldn't get to in the earlier part, so now's your chance. But you heard the rationale behind the ICER rating, and I'll ask them to restate it briefly in a second. But part of this is the short-term, long-term perspective. And you heard that one of the reasons to be somewhat concerned from some people's perspectives about the overall net health benefit is thinking about the potential risks and what we know about its effectiveness over the longer term versus what is seen in 4 weeks. So as you look at the evidence, again, your chance to kind of kick in an early thought on ways, perspectives that you think the evidence can support a certain decision about this question. Dr. Cousine or Gilmer?
Well, first of all, I think it's important to keep in mind the studies were designed to be acute efficacy studies. And it's an acute treatment for a very severe, high acuity state. And frankly, it's no different than ECT, which currently is probably the most analogous in that it's the treatment that we use for high acuity, major depressive episodes with fairly quick response. It has ECT, when effective, has reduced latency of responsiveness, but also much like ketamine, or maybe, we don't know. But one thing to keep in mind about ECT, it is not a maintenance treatment. It's the durability of effectiveness is limited to taking a person out of the acute state. And I'm a mood disorder specialist. I always emphasize there's a big difference between acute treatment and relapse prevention. Chronic major depressive disorder and bipolar illness and the related conditions, they're recurrent, they're chronic recurrent conditions. So I think it's important to be aware of what the data is for long-term relapse prevention, But that's irrelevant if you have a really severely depressed person who's acutely suicidal. If this is an option as opposed to ECT, I think that's worth thinking about. The challenge is, frankly, most of our what are called antidepressants have not been proven to prevent recurrence either. They get FDA indications for acute treatment for 6-8 weeks at best. There's very little true relapse prevention data for any of those drugs. And one of our most effective relapse prevention drugs for affective illnesses is probably still lithium, yet minimally used. So I want to put in perspective that you're thinking about esketamine not as a long-term treatment, but really positioning it as, is it an effective acute treatment for a high acuity person who's non-responsive to other treatments?
Dr. Cuisine, anything you'd like to add?
I just wanted to add a little bit about the side effects. Dr. Atlas was mentioning, I would not prescribe this to a person with high blood pressure, but it lasts for 40 minutes to an hour. And we give some labetalol just before, if it's the case, or amlodipine, and that's it. We have not observed any side effects beyond the time of administration. By the time a patient is released, they're totally fine back to their normal self. Maybe some grogginess the day after, if they have some long-acting metabolites still around, but nothing. We haven't seen anything, any side effect beyond the time of administration, which for us is unprecedented. Most of our drugs, 90% of our drugs cause weight gain, cause a lot of side effects over protracted use. And this is one of the most common reasons for discontinuation: sexual side effect, cognitive dulling, weight gain, I will say in young people, is the major cause of discontinuation. If the side effects are not usually the cause for discontinuing ketamine, is the lack of efficacy, the reason for people to drop out. But side effect-wise, imagine if you're treating patients with stage 3 or stage 4 cancer. These are my patients. The equivalent for depression. Those patients say, I don't care about the acute side effects. If this allows me to live a little better, I will take it. I just don't care about the way I feel for an hour or two if the day after is brighter and I don't feel like killing myself anymore. So this is, again, the concept about treating patients who are acutely suicidal or acutely at risk. And suicide in this population happens. It's just like death in treating cancer patient happens. It's not that we can expect that a patient with depression will leave. The suicide rate in this population, it's fairly high at baseline. So for me, whatever we can do to move the needle, to prolong life, to improve quality of life, it matters. And this is the first drug of a new class that hopefully is going to open the way to new research, to a new way to understand depression. So the same way a new biologic for cancer will be considered. Maybe it's not dramatically more efficacious, but it's a new family, and it's a new starting point for researchers. There are ongoing trials comparing clinical effectiveness between ECT and ketamine infusions. MPCOR is sponsoring one, is a multi-center trial, but we still don't have enough information. We're trying to gather more information to make those decisions. We're not there because we started late.
All right, thanks. Now, quickly, ICER team, reflect again your rating and the evidence behind it, and point, if you will, to tables in the evidence summary that you think are the most important.
I think the comments that have been raised are really appropriate. One of the real challenges for you is this acute versus long-term. So clearly, I think the evidence from the short-term trials does show some short-term benefit across multiple measures. You can talk about how important, how large those benefits are and what may account for them, but the trials are reasonably consistent in that regard. The challenge is that we also know is that relapse is going to occur when stopping them. And so Dr. Gilmer's comment about, well, then what? So this is a very expensive medicine for an acute condition, but then you still got to manage them. The other aspect, just to clarify about depression, suicidality, those patients were excluded from these trials. So one can extrapolate from practice with ketamine, but we don't have really any information about whether this new drug is going to increase decrease or have no effect on suicidality. Presumably, if it helps a great deal with the depression, it very well may, but there isn't any evidence from trial data to suggest that.
Not published, but-
Wait. So so who was excluded? People that had suicide ideation?
No. Sorry, if I can clarify. Janssen, and we have to give credit, did not exclude patients with suicidal ideation, while those patients were excluded for most of the prior trials that led to the approval of SSRIs and SNRIs. But they're excluded patients if they were at immediate risk and they needed hospitalization. Otherwise, they would be allowed in the study.
I'm sorry, thank you.
Yes. So that.
Yes. I'm talking about people that you're giving the therapy because they are exactly. That was a little bit of the implication, but I think Dr. Kusin's clarification is helpful.
And Janssen is conducting a trial in emergency room setting for administering esketamine to patients who are at imminent risk for suicide, and they need a hospitalization because they probably have decent preliminary data on that.
So this leads into the question I had earlier that goes back to what Tim was saying. Part of your rationale for giving this a PI was concern about increased suicide ideation. Did you account for the fact that, as far as I know, every antidepressant comes with the warning, and there is some percentage of folks that when they take it, it increases their suicide ideation? Did you account for that and say it's the same, it's bigger than the other drugs that are on the market, or is it just that it existed, so we're going to give it the PI?
Yeah, I mean, that's a great question. That gets at the comparative data, and as we really highlighted, there are many existing medicines that are available to clinicians and patients. They all have their pros and cons. There's no data that provides that comparative effectiveness in terms of this risk.
There's no studies on other drugs about the percentage increase in suicide ideation of that antidepressant?
The difficulty is that you're often in these studies, what we found, comparing apples and oranges, that fundamentally the patients with depression represent a broad spectrum, very heterogeneous in terms of the severity of their symptoms, the duration of their symptoms, other medical issues or psychiatric issues that may come into play. So it's very difficult to compare. Yes, there are results that one could compare, but I don't think that those comparisons would be meaningful.
And it might be helpful, just again, we have a few new members to the Midwest CEPAC for this meeting, a little bit of the history behind how we interpret the promising but inconclusive. It is a zone where we often find ourselves when we're looking at treatments near the time of FDA approval, to be honest, because all that means is that we could have our best point estimate of where we think the net health benefit is be pretty positive, but we think that there's enough uncertainty that there's a 10% or less-ish chance that it could actually be worse than, in this case, doing nothing. So where does that 10% or less chance of being worse come from? It would have to come from increased risk of suicide when you try to take the drug away. There's some evidence that hasn't been talked about yet, apparently, that for ketamine to be successful in its treatment, it has to trigger opioid receptors in the brain. So we don't know completely yet the neurochemical long-term. So there's less than 10%. There are some clinical experts out there who are saying this is the next time we're going to get fooled into something that's not going to create an addiction problem of some kind, even though it's going to be managed in a way that it can't be diverted. So again, there are strongly held feelings about whether that's a significant concern or not going forward. But just to frame why, even if we think the net benefit might be incrementally better or even substantially better, that's where in some cases we have some unknown risks, if you will, or small indication of potential risks that leads to that PI.
I just wanted to make one additional point, which is we're talking about suicide because we can kind of understand what might have happened there. These we don't have an enormous number of patients treated in these trials. 6 people receiving esketamine are dead. 1 of those was an accident. This drug affects cognition. 3 of them were suicides. 2 of them maybe seem less related. But we have some deaths. And this gets at we don't have a whole ton of patients treated with this therapy. We don't have a lot of long-term information. And that PI reflects us being nervous about it. It's fine for you all to be less nervous looking at the data. You can look at this and go, yeah, I'm not so worried. It's just like ketamine. And we have a lot more experience with ketamine. And so maybe we shouldn't be that worried. And that may be a reasonable position to have. I find the ketamine stuff reassuring. The pharmacodynamics of nasal esketamine are quite different from IV ketamine, and we probably have a lot more experience with IV ketamine because of all the ketamine clinics than with other administration methods. So that's part of what goes into looking at this and going, yeah, maybe. I'd also, if you go down the path and go, well, it's just like ketamine, that will probably inform some of how you might want to think about the relative value of a drug that costs what esketamine costs versus what ketamine costs.
All right, back to the panel. Tim.
So I think that's helpful to hear, and also then from our clinical experts. To me, all the concerns about it versus background antidepressant alone are similar to the concerns that I've heard about many other drugs. They're often FDA approved short term, and then we try to extrapolate for longer term. That's just what happened this morning. It happened in the asthma situation. The benefits, we have an MID for a patient-reported outcome that is 2 to 3 times larger, the effect size, than the MID. That's far larger than what we saw for the asthma drugs. We see improvement in relapse and remissions, the discussion about how some of these really should be for the acute phase. We've got consistency across multiple studies and multiple outcomes of a population that, when you add them all up, is in the several hundreds. I just think there's inconsistency in how we're weighting the benefits and harms versus other things we've done, and particularly for this question, against background antidepressant alone, when basically they've run through every other drug that's out there. So it's not like you can switch them to another drug. They've already been there, tried that, ain't happening. We could argue whether just trying them again and recycling them might work, but that's not what I'm hearing from our clinical experts.
All right, Reem?
I think it's really all about the values we're putting on the evidence. Each of us is putting our own values on how we're looking at it. And honestly, to me, those deaths, especially the suicides, I understand that there is high risk of suicide in this population, but it was not that the 2 groups had the same rate of deaths. If that was the case, then I would be. So to me, again, it's weighing, it's the net benefit and weighing risk and benefit. And that's why I asked with the modeling, did you account for that? To me, that's a very important, it's an important signal. Some of us may feel just more comfortable than others with it, I think.
Great. I just want to say on the other side of that, those deaths, 1 suicide was, I believe, or 1 death was during the controlled period. The others were during open label, so there was no chance for the deaths to occur in the control group at that point. So 5 of the 6 deaths could only have occurred in the esketamine group, 1 of them. So we have 1 versus 0 during the control period. That said, I still, as you hear, remain concerned that it was a high number of deaths, but it's not 6 versus 0 esketamine versus control.
Eric, and then we should probably try to move towards a vote.
So the only thing I'm trying to do is I sift through the data, is reflect on and check my own biases regarding evaluating and thinking about mental health and behavioral health conditions when we think about these things. So do we weigh adverse outcomes in a different way because the underlying condition is mental health? or do we value it in some different way? And I'm just telling you, like, that's one of the things I'm trying to check myself on as I go into this vote and have really thought about the discussion that's gone here today. And so I just want to say thank you for all the expert opinions that we've had that have, I think, challenged some of the assumptions and biases that we bring just because we're human to a condition like this.
All right, thank you. Let's go ahead and vote, please. A is yes, the evidence is adequate for esketamine plus background antidepressant versus background antidepressant alone. B is no.
Steve, for TRD, right?
Yes. We are waiting for one more vote. There it is. 14 yes, 3 no. If I'm not mistaken, the FDA advisory panel's vote was like 15 to 2. It was very similar, wasn't it? All right, interesting. I think for the sake of allowing us the time we need to talk about the other benefits and the policy discussion, again, I'm not going to dissect a postmortem on the vote. Thank you. Let's move to the next vote, which is comparing whether we can, sorry, it's not comparing, it's the question is whether we can distinguish, is the evidence adequate to distinguish the net health benefit between esketamine plus that background antidepressant and ketamine plus the background antidepressant? ICER staff, again, can you summarize the data that do exist or don't exist on this and the rationale for our judgment?
So as presented, we presented one phase 2 trial. There's large differences between the patients, particularly around the placebo response. So if you looked at a relative benefit in that trial, it would have emphasized that ketamine looked more effective. When one looked at the absolute rates, they were similar, though the nature of the administration, the duration of the follow-up, the nature of the populations did not allow us to feel like we could do a meta-analysis, and that's why Dan only presented a cost analysis.
All right. Anything else to add on that? So one head-to-head trial, right? No, I'm sorry. Oh, forgive me. No, 0. So it was, of course, because the placebo groups were very different. Okay. I'm going to get into the clinical aspects of if you had a patient in front of you, which would you pick for the clinical experts, but we'll get to that in the policy roundtable. Nick.
Sorry, do we know what accounts for the lower placebo response rate? I'm just confused about whether to think about ketamine as being superior in this trial because of the bigger relative change, or whether or not I should think about it as being roughly equivalent because of the absolute number. So I'll admit to being confused.
The fear would be that the trial has a low placebo rate because of unblinding, and that patients realize the difference between whether they were getting...
Why wouldn't that have been in the esketamine trial, too?
So one possibility is that the trials were run somewhat differently. There's a phase 2 trial versus a phase 3 pharmaceutical company-run trial. Another possibility is that IV ketamine causes dissociative effects more than nasal esketamine. And so to the extent that placebo response is usually larger, much larger than was seen in the placebo arm, you're sort of suspicious that the people getting placebo knew they were getting placebo. But that's just supposition. It may actually be that ketamine works way better, and we're undervaluing what that trial showed.
I guess, just to follow up, if you're the placebo groups in both studies, neither of them would have had any effect, and yet the blinding, I guess, why would there have been differential unblinding in the two studies if they're both getting placebos?
The side effects with 28 milligrams of esketamine are much, much less than an infusion. So those are immediate. They hit you right away within 10 minutes. You know if you're taking. This is why most of the follow-up studies were using intravenous midazolam as active control and not saline. That study was early. But there is a lot of other studies that were controlled, ketamine versus placebo, that had as expected placebo response rate of 25, 35%. And still, all the studies were positive. except my study, and I suspect that that was because there was patients that were much, much sicker than all the patients enrolled at NIMH and at other sites, and I discussed with other investigators. Our patients had failed between 8 and 15 antidepressant trials. Half of them had failed ECT. So those patients have a placebo response rate that is really negligible.
Okay, other questions about the evidence on this? Eric, did you still have a question, or you're good? Yeah, I'm sorry, Dr. Gilmer. I apologize. See you doing it. Can you use the...
Sorry, was the duration of the lead-on on the antidepressant alone similar for both S-ketamine and the ketamine trial? So the time period leading up to the randomization?
Ketamine, there was no.
There was no.
No leading.
So it was actually okay. So you're not dealing with ketamine was ketamine alone, no antidepressant.
Added to an antidepressant, but it was whatever antidepressant they came in.
But how long were they on the antidepressant?
Whatever
Because that
period.
could differentiate, because you're really talking about an augmentation strategy, and so the duration of lead-in has a significant impact in terms of what you see.
Okay, so thank you.
I just don't remember
Steve.
off the top of my head.
Okay.
Yeah, I was just going to add that they had similar duration leading onto it. The difference was that for S-ketamine, they started new antidepressants, while ketamine, they continued on the background antidepressant they had failed.
Okay, that's very different.
That's interesting.
And the other thing I was just going to add to the functional unblinding is that for the ketamine trial, by the end of the trial, most people on the placebo arm had dropped out, so which sort of led us to believe that most people knew they were not on the active treatment.
Okay, so let's go ahead and vote then. Is the evidence adequate to distinguish the net health benefit between S-ketamine and ketamine? All right. You guys certainly found consensus there. So let's go to a very important part of every discussion. Oh, I'm sorry. We're going to skip these because we had the answer was. Oh, wait. We know we do this one. So we did vote yes that the evidence was adequate to say that esketamine is better than just background antidepressant. So here the question is the evidence adequate to demonstrate that the net health benefit of esketamine plus that background antidepressant is superior to that provided by any of the other following treatments, TMS, ECT, or olanzapine? I know this seems like we're asking you to compare apples, oranges, and giraffes, but Steve and David, can you reflect again the amount, type of evidence that we have and the rationale for the ICER judgment?
So we did not this afternoon, present the direct evidence in the report itself. We highlight the evidence for ECT, TMS, and for the olanzapine trials. I would emphasize that the differences in study designs, populations, outcome measurement, duration of follow-up were even larger between those trials, within those trials, and the esketamine. So relatively speaking, the ability to indirectly compare the results was not something we felt we were able to do.
Phyllis.
Just want to provide a patient perspective on that when it goes back to what I said in an earlier comment that 21% of the people in the respondents in the survey said that they had switched medications for a health reason, and 51% said that they were not taking any medication for a health reason. And when you consider the side effects of olanzapine, such as the enormous weight gain, that it could, we didn't ask the people in the survey what they were switching from or why they were switching, but in addition, there is, the rare possibility of acquiring tardive dyskinesia with olanzapine, which, as you know, is a permanent movement disorder condition. So I think when you're looking at overall net benefit, it goes back to my comment earlier that, there is just this unmet need of having, good products available.
Thank you. Pamela, please go ahead.
One of the other issues is that ECT is truly effective for many people, but it involves months of reduced memory and cognition. And I know that in my case, instead of returning to work, I would have had to be taking a long leave of absence to get any benefit from it, which is very life disrupting for someone who's trying to stay fully employed.
All right, thank you. Oh, we do? Okay. Oh, because I went forward? I broke it. All right. Any other question? Thank you, by the way. Thank you. Are there any other questions or comments from the council? Okay. Please go ahead and vote. Is the evidence adequate to demonstrate that esketamine plus background antidepressant is superior to other options? I think we should have 16 votes now.
Stuart just left, and he's going to be
Right.
no.
Oh, okay. We already do have one. So we need one more vote, I believe. There we go. Okay, 16-0. I know, 17-0. Stuart had to leave, but he recorded his vote before he left. Okay, so that was also a unanimous vote. So now we are going to move forward to the potential other benefits and the contextual issues. So let me just, again, step back just for a sec to frame what we're trying to do. We're trying to examine elements of value that may be important depending on your perspective, but that which we would want to be factored in potentially into the thinking of different decision makers. So in particular, we want to know whether these are aspects of value, and they can be benefits or disadvantages, that are not captured in the clinical data or in the cost-effectiveness modeling. So, does treating patients with esketamine plus the background antidepressant offer one or more of the following potential other benefits or disadvantages compared to other approved treatments for treatment-resistant depression? And so these are shorthand versions. What we ask are, will the intervention significantly reduce caregiver or broader family burden compared to other approved treatments for TRD? Does it offer a novel mechanism of action or approach that will allow successful treatment of many patients for whom other available treatments have failed? Does it offer significant impact on improving the return to work or overall productivity of patients? And D is other. Are there other important either benefits or disadvantages that should be factored in? We've heard, I think, very usefully from the patient commentary some of the factors here. So let me just first turn to the council. Do you guys have any questions or thoughts initially coming into this vote that you'd like to ask, or again, comments you'd like to make? Nick?
You mentioned the studies suggesting that maybe ketamine wasn't an NMDA response. It was, in fact, an opioid response. I was curious to get the clinicians' views about that possibility.
Sure.
Without entering in me arguing about the politics of publishing one teeny tiny study on a very high impact journal and highly cited, there are different groups that have been trying to replicate that study and have not been able. So there is a fair amount of skepticism about a former director of that journal publishing his own paper on that journal. That makes us cringe a little bit because everybody asks about that question, and we are a fair amount of skepticism. Let me put it this way.
So there's uncertainty about that uncertainty. Good. Any other, David?
Again, I just want to highlight that for this question, it says other approved treatments. So when you think about novel mechanism of action, ketamine is excluded.
Right. So we're not comparing esketamine to ketamine. We're comparing it to the other previously or currently available approved options. Tim?
Did the modeling include all, I can't remember this,
so here,
information to guesstimate caregiver burden or significant impact? I think it comes back to Eric's question of, yeah, it's potential, but was it included?
I need to answer that actually because it's an important distinction. I'm making this point partly for the new members of CEPAC. We always do a healthcare sector perspective as our base case, and we do a modified societal that tries to capture things like productivity. In a sense, we are asking you, from what you learned about that or other aspects of the testimony and information you've heard, do you think the healthcare sector model is missing significant impact on reducing caregiver or broader family burden. So that means that you might have seen it in the modified societal perspective, and we're asking you to say, yes, that was significant, I could tell. Or, again, sometimes, again, this is part of why it's value judgment. You have to decide how much impact is significant. So, Dan, if you want to comment on that, when you tried to capture that impact, what effect it showed?
Yeah, so we did try to capture this. We had one very relatively small study that looked at only those patients who were working. That's what we included in our model, and it reduced the ICER by about $10,000 per quality gained from 198 to 188.
All right. Phyllis, please.
I just want to reiterate what we said in our comment earlier, that at our patient-focused drug development meeting that we had last November, we heard over and over again, which was interesting and surprising to the FDA. The former director of the FDA mentioned this the first time he'd ever heard the idea of underemployment. So we heard over and over again from people that while, yes, it's one thing to return back to work, it's something entirely different, which we heard over and over again, to work up to your full potential and to your full earning capabilities. We heard comments such as, I was not able to interact with my supervisor in a way that I could get a promotion. So I think that's missing when we look at the economic value, when we look at productivity, return to work. What is the level of underemployment? We had heard from people who had, a woman who had an MBA and was working as a substitute teacher. So there clearly is, an underemployment issue going on there.
Thank you. Thank you. I know many people who work at the FDA. I'm surprised that an ex-director of the FDA was unfamiliar with the idea of underemployment. So,
Can
yes,
I just
Ryan.
add to what Phyllis just said in terms of I think there also is a benefit not only to the individual being able to maybe go back to work or gain full employment, but the caregiver, even if they continued to work, they were not fully present. I may have some experience with this. They were not fully present at work. They were not fully functioning at work. Yeah. They couldn't work full time. And there is a huge economic benefit, which I think is missed in the economic analysis of increased caregiver employment and productivity in their own job.
Yeah. And I'll say it now, I'll say it later too. I can't emphasize how nice and useful and critical it would be for future research to build in a few simple questions that could capture this impact on patients and their families. We hunger for that information. We sense the importance and the impact. To quantify it ever better would be important for everybody. I think somebody else had a question, but we do need to move relatively quickly. I'm sorry, Dr. Gilmer, did you need?
I just a comment about B, but it relates to the others. And it's important to remember that recurrent major depressive disorder, the type we're talking about, recurrent affective illnesses, they're treatment resistant, they're chronic conditions, tend to be early onset, and they're progressive. The pathophysiology is progressive. Yet for some reason, we have no problem thinking about changing treatment paradigms with any other chronic illness. You would not treat someone with hypertension or early onset type 2 diabetes with the same treatment 20 or 30 years later, nor would you do that for any other condition. Certainly no other medical neurologic illness that affects especially the central nervous system. Think about Parkinson's, for example, or MS. Why would we expect that someone who maybe responds to sertraline, or I'll use that, or any other SSRI, their first episode at 18 or 22 is going to remain responsive to that family of drugs or anything else of that genre 10, 20, 30 years later? Yet that's exactly what we do. And that's the problem with assuming that all the Me Too drugs that we have that are now generic and maybe more affordable alternatives, that they're going to be effective. The reality is that evidence shows that with each successive treatment failure, you're less likely to respond to another treatment. I was a PI on the STAR-D trial, which was referenced earlier. By the time you got down to the fourth treatment trial, your likelihood of remitting was 15%. That was after just 3 previous trials. These drugs, ketamine and esketamine, I'll put, they represent the first novel mechanism in 6 decades that we've had for treating these very serious, recurrent, and progressive conditions. So that's why this treatment and the questions that you're looking at are so important to the folks up here at the panel.
Great. So we're going to vote on them. And again, just from a procedural perspective, I want to add the other that Nate, I'm sorry, I forget your last name, but the point raised that for public insurers, there's a potential other benefit of increasing productivity, it's linked to that one, and overall well-being to the point where they will no longer require public assistance at all. So that, I'm just going to give that a unanimous vote on that one. So let's go ahead and vote on these 3. And again, I'll need to see your face up at the screen or at me to know that you're done. Ryan, you're still voting? Okay, all right. So let's see the results. Okay. 9 out of, it's now 16, said reduce caregiver family burden significantly. 14 out of 16 said a novel mechanism of action or approach. 12 said significant impact on improving return to work or overall productivity, and 4 other. Let me focus real quickly on the others. If we can try to be brief, if you want to introduce them into the record, what would they be? Unless you were voting on my other, I hope not. What's that?
You convinced me on the payer.
The public insurer. Is that what you meant by other? Yeah. Oh, okay. I was already writing that one in. Any other others? Yes, Jill.
I'd say it's not as invasive.
But you were comparing it to ketamine, to some of the others. Okay, I got it. Because TMS is not really.
That's what I thought the whole question was on. So if the previous question was unanimous that there's not, the evidence is inadequate for esketamine versus approved treatments, logically, I don't know how A or C compared to approved treatments could have any votes.
Because we've said that there's not enough evidence to see that. I think that's why it could be a mixed vote. It could be a mixed vote. Okay, but any others? Again, sometimes I just want to make sure that we capture for the record. Okay, for contextual considerations, this is about esketamine plus background antidepressant treatment, and basically just saying in the bigger picture, the context, is this related to care for individuals with a condition of particularly high severity? Is it a treatment for patients with a condition with high lifetime burden of illness? Now here we have compared to the comparator, and we don't have the comparator in the language. I'm trying to remember what we had intended. The C and D are meant to try to capture whether there are really significant uncertainties about the long-term risk of serious side effects, and D is about the maintenance, if you will, of the benefits that are seen in a short-term study. There's always some uncertainty. This is to ask you whether there's, in a sense, particularly significant uncertainty as a contextual consideration around the value of these treatments. Now, I'm going to take prerogative to see if anybody objects to the idea that we've talked about this a lot, and I think it has factored into a lot of the earlier conversation today. But if there's a specific question or perspective that someone wants to introduce, such as the chair, he has that prerogative.
I was just going to give you my other first. Can I give you my other first?
Yes, yeah, okay, sure.
I'm going to give it
no, please.
So, because I don't think it's an A or a B, I think it's something slightly different, which is the comorbidities that are associated with severe mental illness or depression. And so I'm taking into consideration the reduced life expectancy of people with SMIs or treatment-resistant depression into my calculus of how I think about the long-term value of money in this group. Yeah.
Okay, so noted. I think we'll take that with acclamation, basically, as an important factor. Okay, please do go ahead and vote then. All that apply, A, B, C, D. You don't have to vote on E unless you have a different other that you'd like to introduce to discuss afterwards. And I'll look at your faces again to see if they're looking upwards. You're done. Okay. Albert, are you still working on it? You're done. Okay, here we go. All right. 14 out of 16, care of individuals with condition of high severity. 13 out of 16, strong majorities for all of these. Care of individuals with high lifetime burden of illness. There is also a lot of significant uncertainty here, as noted by these votes, in the long-term risk of side effects and the durability of the benefits. 4 others. Anybody want to tell us quickly what they were? Reem? Sorry, can you use the...
I considered underemployment here, that it's something that we really have to take into consideration, not just the benefit.
Okay. So that we would call that usually an other benefit instead of a contextual issue, but we'll make sure that that gets captured. Anything else in the other category here that people wanted to note for the record? Okay, you can tell us later. Maybe you were, again, voting in favor of something that Eric already said. But that's a very helpful, and for those of you who haven't been part of an ICER process before, these get packaged in our final report and are part of even our summary, shortest versions, so that we send an important signal to decision makers that it's not just about the clinical outcomes in the studies and the dollars associated, but there are broader considerations around value that are important for everybody to be aware of. So thank you very much for that discussion. We are going to take now all right, 10-minute break. We still have to do it because we can't go all the way through to 5 without people probably exploding. So let's go but please try to be back in your seats by 5 of, so that we can launch right into the policy discussion. We're going to talk about coverage, we're going to talk about research, and how we can do it to favor the kinds of evidence we need for patients in the future. So be back at 5 of, please.